A very good afternoon, everybody. Thank you for joining this corneal subspecialty national CME organized by Academy of Medicine Singapore. My name is Ray Monotosh. I'm one of the consultants at National University Hospital. Today, I'm privileged to introduce Professor Christopher Liu, who doesn't need any introduction. Professor Liu is a consultant ophthalmic surgeon at Sussex Eye Hospital, Brighton, UK. He is also an honorary clinical professor at Brighton and Sussex Medical School. Simultaneously, Professor Liu is an honorary professor of ophthalmology at Kindai University Medical School, Osaka, Japan, Chinese University of Hong Kong, and visiting senior consultant at Aarhus University Eye Clinic in Denmark. Professor Liu is also an undergraduate ophthalmology lead as well as research lead in ophthalmology at Brighton and Sussex University Hospital, NUHS Trust. He was appointed as the officer of the Most Excellent Order of British Empire by Her Majesty Queen Elizabeth II for his services in ophthalmology in the year 2018. His research interests include keratoprostheses, clinical optics and biomaterials. He has published extensively, more than 250 research articles in peer-reviewed journals and over 10 inventions in ophthalmic literature. Professor Liu will be updating us today on various forms of keratoprosthesis this evening. So without further ado, let us welcome Professor Liu. Over to you, Professor.
Well, good evening, everybody. Panelists, can you confirm that you can hear me?
Yes.
Wonderful. Thank you very much, Prof. Ray, and thank you for the opportunity to speak to Singaporean colleagues, updating you on the field of keratoprosthesis. And basically, I will be concentrating on the OOKP, which is my forte, but there will be a few slides on the Boston keratoprosthesis type 1. So just a declaration of interest that in Brighton, we are one of a very small number of international referral centers capable of offering OOKP surgery. And we have in fact been funded by central governments in the UK, and the OOKP service will be moving home shortly later this year. What are keratoprostheses? We have temporary K-pros, for example, the Eckhart for carrying out VR surgery when there is no view through the cornea. There is an attempt to replace cadaveric corneal transplantation, for example, the collagen construct by May Griffiths. But really, this evening, we're talking about restoration of sight in desperate cases of corneal blindness, which are not amenable to conventional keratoplasty. And these keratoprostheses or artificial corneae bypass the ocular surface and the host cornea, and they are very much a last resort. Basically, we are now down to 2 keratoprostheses still in clinical use. There are variants, which I will talk about a little. Now, for the so-called wet blinking eye with no bulbar or tarsal keratin whatsoever, then the procedure of choice would be the Boston K-Pro type 1, and it can last up to a few years. I mean, occasionally they can last longer, and they do much less well with autoimmune disease. And you can see a picture of the latest incarnation of the Boston K-Pro with an optical part and a titanium backplate. Previously, there was a PMMA backplate also fenestrated for nutrition of the stroma, and then a further titanium locking ring. But this now the titanium backplate doubles as the locking ring. So the other K-Pro is the OOKP, and this is used for the dry eye or where there is lid defect or incomplete blink. And the OOKP is best done with the patient's own canine tooth because an allograft tooth does not do nearly as well. And this can easily last for up to 10 or 20 years or even beyond. And here you see the clinical appearance of an OOKP eye. Everything is covered with buccal mucous membrane taken from the inside of the cheek. And the cross-section shows you that it's a uni-chamber eye with a very little content within the eye because the iris, lens, and much of the vitreous has been taken out. And we will go back to revisit this anatomy. So when do you use a keratoprosthesis? Well, in bilateral corneal blindness or where there is corneal blindness with one remaining or only eye. And the patient really needs to have a strong wish to regain sight. We need to be doing the surgery for the patient and not for the relatives, and certainly not for our own entertainment. When we want to do surgery, we must only do surgery when we need to do surgery for the patient. So informed consent and understanding of the inherent instability of all keratoprostheses, even the very stable OOKP is inherently unstable. So if patients do not want to take any risk, then they should just stay put as they are. There will be formal psychological assessment to make sure that they're robust for the surgical program. And also in case of device failure later on down the line, that they need to be robust enough to cope with that. Otherwise, we do not want to jeopardize the psychological health of a patient. Obviously, there should be sufficient family support and preparedness for lifelong follow-up, regular follow-up, and possible further procedures. I will go into psychological assessments in a little bit more detail in a moment. Now, remember the metrics of success for keratoprosthesis. There are various categories. So let's look at anatomical success to begin with. So initial anatomical surgical success means that you've completed both stages of an OKP or one stage of a Boston K-Pro. Now, that's quite easy to achieve. And I think once you've become an experienced surgeon, then you can be pretty sure that in the far majority of cases, you will achieve that anatomical success or surgical success. Then when it comes to retention, that's a different matter, not just of the device, but also retention of vision. Now, retention of device, less than 2 years is called short term, and 2 to 5 years is called medium term, and greater than 5 years is long term. Now, unfortunately, a lot of the publications are only short term. Some are medium term. There are very few long term papers published. But this is actually very important because for the majority of patients, you implant a keratoprosthesis, they will live longer than 5 years. So you can see how important it is to report your 10-year and 20-year results. Now, in terms of visual success, even within this category, there are subcategories such as visual acuity and visual field. Now, you may have very good visual acuity, but if your visual field is very narrow and the patient keeps bumping into things, then that's not great either. Equally, in all keratoprostheses, there will be some degree of glare, and of course, that can limit visual function. And so the third category of metric of success is your patient's reported outcome measure. And so the patients need to be happy with the results. And of course, they should be happy with the experience of their journey as well. So let's have a look at the Boston K-Pro Type 1 in a little bit more detail. Now, here is one I prepared earlier, and this is using the previous PMMA backplate with fenestration. And if you look carefully, you can see the front parts, the optical parts of the Boston K-Pro Type 1. And behind is the backplate. You can't see in much detail, but here you can see a corneal graft, a full thickness corneal graft, which is the carrier for the Boston K-Pro. And you can see that there is suturing, usually interrupted sutures, because you don't want one suture loosening, an area of loosening to affect the whole integrity of the eye. And on top of that, you can see a very large diameter bandage contact lens or therapeutic contact lens to keep your cornea hydrated and protected from proteolytic enzymes as well. Here you see some mucus being accumulated underneath the contact lens, but in the furrow where there is tight stitching. Now that we have anterior segment OCT, you can see the anatomy every time they come back for quarterly checkup. Here you can also see through the optic that there is no retroprosthetic membrane formation, and this is quite a common problem with the BK Pro 1. So as mentioned, here is a cross-section, and you can see the optical part, and here's the back part, and here you can see the carrier corneal graft, and you can see that there is no loss of tissue, and you can even see the mucus being trapped underneath the contour, large diameter therapeutic contact lens, which is replaced on a monthly basis. So I've already said that it uses a corneal graft as a carrier. the infection rates, which used to bug the Boston K-Pro type 1, has improved greatly, both corneal infection and endophthalmitis, because of the introduction of lifelong topical antibiotic. Now, in some climates, an antifungal drop is also used on a regular basis, and in many places, then after removing the contact lens, then the eye gets irrigated with povidone iodine too. However, there is still keratolysis and keratitis, infectious keratitis, despite the use of a therapeutic contact lens and despite regular use of antibiotic. And these are the problems, retroprosthetic membrane formation, which are really to do with inflammation and escape of keratocytes through the graft hose junction into the inside of the eye and then coating the back of the device. That's still a problem. Sterile vitritis is a problem. Sterile vitritis is probably a low-grade endophthalmitis. And glaucoma is also a big problem, and the majority of cases will or have already had a tube or will have a tube. Variants exist, so you have the Lucia, which is a low-cost option for the developing world. Now, the Boston K-Pro type 1 must not be confused with the type 2, which is a much longer device for use through the lid in a dry eye situation. There are very few papers on the Boston K-Pro type 1 with a longer than 5-year follow-up. Now, in my books, I would not use it in unilateral corneal blindness, although there are practitioners who will implant in unilateral blindness and will implant bilaterally in bilateral corneal blindness. In my view, if there is a good eye, then I wouldn't convert the bad eye into an unstable situation. And when there is bilateral corneal blindness, I would keep the other one as spare when to use when the first one fails. So I would avoid using the Boston K-Pro type 1 in any autoimmune disease and in dry eyes and in eyes with any degree of keratinization, either bulbar or tarsal. And here's a publication if you want to look it up, a systematic review and meta-analysis of the medium and long-term outcomes of the BK Pro. So there is tension as to whether Boston K-Pro can be used as a primary procedure. So as I said, the surgery itself is relatively easy, apart from the suturing. The suturing is more difficult because there is a backplate and that makes the suturing more difficult. And all K-Pro surgery, including Boston K-Pro, should probably be best done in highly specialized centers where there is subspecialty support and also a 24/7, 365 hotline or emergency service whenever there is a problem. So now I want to move on to the dry eye, and you can see some examples of the sort of eyes that we're talking about, where there's a loss of fornix and a highly keratinized and bone dry situation. So obviously, people may ask, oh, would stem cells help? Well, the answer is no, because the stem cells will die immediately you put them on because the ocular environment is too hostile for any cells to survive. So which keratoprosthesis? Well, definitely not the Boston K-Pro type 1, which is for wet blinking eyes where there's no keratinization, etc., etc. So we really, this sort of eye is the territory of the OKP or osteodontokeratoprosthesis, which in Greek stands for bone, tooth, artificial cornea. This was invented, the procedure was invented by Benedetto Strimpelli, who passed on the knowledge to the late Giancarlo Falcinelli, who was my teacher. Now, Falcinelli would not have been the natural successor of Strompelli, because there was actually a Professor Marchi at the same institution. But Falcinelli showed an interest, and then over a 20-year period, he made incremental improvements to make it a success. And then he also took on a number of disciples. Now, his results were very, very good, and has not been matched by any of his disciples or disciples of his disciples. And here you see the retention results of 89% over a 27-year period. However, his case mix was different from what we do the OOKP for nowadays. So there were wet blinking eyes included in his series, and that's because of a dearth of corneal donor material in Italy of those days. So here is a very, very out-of-date mentoring tree of who Falcinelli taught, because units have come and gone. So, I mean, this is actually quite interesting history. We could have a very quick look at it. So of the 3 original disciples, now Grabner, Professor Grabner had retired, and his identified successor was no longer interested, and now he's doing refractive surgery. Professor Hiller recently retired, actually only this week, and he was telling me how wonderful his retirement party was. So I think Professor Gerling is likely to be the successor. So myself, I will tell you the various people I have taught. Now in Egypt, Professor Munir no longer was interested, and now the OOKP technique is done in Alexandria by Professor Bhagat Goeda. Chennai, interesting and also sad that Professor Sita Lakshmi passed away all of a sudden, but now the unit is thriving, and the most is one of the most advanced OKP center and ocular service center headed by Dr. Geetha Iyer, whom I'm in regular contact with. Hong Kong, you see my colleague here who is no longer interested, and the cases were coming to Singapore until I understand recently the OKP service at the SNEC is no longer so active. Liège in Belgium, and so on. And look at the Miami situation. Miami, Victor Perez only did 4 cases, but unfortunately, the situation did not work in America, and so that service was closed, and Victor has moved on to another institution. This was at the Baskin Palmer. So let's have a look at patient selection for OKP. So similar to the Boston K-Pro, in my books, both eyes should be blind, and the better eye should be counting finger or worse. Otherwise, when you rehabilitate the worse eye, there may be rivalry between the two, because the OKP image is different from a natural image from the natural eye. So the worst eye or the only eye will be rehabilitated, and the other eye kept as spare. Remember to treat any glaucoma and do a B scan periodically, and review the visual potential also from time to time. The left eye, sorry, the left-hand image is just a stock image. It's just to keep the slide interesting. It is not a clinical photograph, okay? So now the patient journey. So they come through a multidisciplinary OOKP assessment clinic. So ocular assessment, obviously, projection in quadrants, assessment of the IOP with your fingertips, and then A scan, B scan to check axial length and the lens status, and to make sure that the retina is intact. Now, in terms of electrodiagnostics, often that is not necessary, because if there is a very good perception of light and accurate projection in quadrants, and the ability to distinguish a blue light from the green light when you're testing with the indirect then you know the retina is mostly okay. Oral assessment, you look at oral hygiene, gum and bone recession, presence and state of canine teeth, buccal mucous membrane on either side of the cheek, and then they go through X-ray, so not Ian Francis anymore, Panos Kumelis, usually an OPG. It could be individual X-ray of canine teeth. It could be a CT scan as well. And really, we would be looking at, we're looking for the longest, straightest, and thickest girth of canine tooth roots, and looking at the relationship to surrounding teeth as well, because we try to limit damage to surrounding teeth when we harvest a block of tissue. And also to look for bone loss, because you need the bone to come right up towards the crown. If there's a lot of bone loss, then the tooth is not good enough. So psychological interview, we will look at this in a little bit more detail. So what are we looking for then? We're checking formally for psychosocial assessment. So we'll be looking for mental health, both current and previous. We're looking for the amount of support there is. And coping style, this is all psychological speak. So I leave this to the psychologist. And so here as well, she helps me a lot with explaining the procedure more in lay terms so the patient can understand. So the psychological report is very detailed, and it comes usually in 2 or 3 sides of A4. So how does she help me then? Because she then helps me by giving me a traffic light system so that it's red, green, or yellow. Now, the patient has a lot of turmoil. They think about whether the OKP might fail. What about visual restriction in terms of visual field and glare? And what about the reactions of others and the withdrawal of support from people who are helping them? There are mental health issues as well. Then there is identity, because once you become blind, you assume the identity of a blind person. And when you become sighted again, you don't necessarily, you lose the identity of a non-sighted person. But because your sight is not perfect, you don't necessarily gain the identity of a sighted person. So you could end up being in between, in no man's land. And it takes time to acquire new skills of literacy and body language. And also you have to prepare yourself, because if you've been blind for a number of years, when you look at yourself again and see your friends and even look at the cars and fashion, everything has changed, you know, like all of a sudden, because it's been several years or even 10 or 20 years that you haven't seen. Okay, and you worry about your cosmesis as well, not only because of the altered look of the OKP, but if you've been subject to chemical injury or thermal injury or Stevens-Johnson syndrome, you look at yourself, there will be change of facial features, which can be quite a shock to yourself. And also you worry that if you got married or you are in a romantic situation, you have never seen your partner and you see them for the first time, that is quite anxiety provoking. So luckily, I don't have to worry about this too much, because the psychologist has been in place for a dozen years. Before she came along, Dr. Angela Bustil, I was the psychologist as well, and I took all the burden. Now, basically, she tells me whether it's a green light, is a yellow light with caution, and what needs to change before we do OKP surgery, or whether it's no go, in which case then you know, we just don't go there. So her support is very important in assessing patients, and also when it comes to time that the device might be failing, then her support to the patient and to me is very important. So now, what about the patient journey then? Having been assessed and deemed to be suitable for surgery, then the surgery is basically in 2 stages, and each stage can last up to basically a whole day GA list, and then staying a week in hospital. And then the 2 stages are 3 or 4 months apart, and they can return home between stages. And often patients would have come from far afield, either from the same country or from neighboring countries, sometimes from faraway countries too. So let's have a look then. So stage 1, you can see that the tooth is not just extraction of a tooth, but rather a block of jawbone as well. And you try and not disturb the surrounding teeth. The crown is not used apart from being used as a holder whilst you prepare the tooth root and the surrounding jawbone into a plate or a lamina. And you can see that a hole is made, or a tunnel is made through the center of the dentine, where there is a minimal girth of 6 millimeters. And then after that, you put in the optical cylinder, and that is fitted tightly, and any cement which is put in there is really act as a filler. Cement is not, dental cement is not an adhesive. And at the same time, you have the stage 1B, so stage 1A of the eye, that you harvest a buccal mucous membrane and you take away all the scar tissue. You can reuse some of the scar tissue for relining the upper and lower lid, the posterior lamella. And then you find your recti muscles. And if the cornea is not vascularized, you have to advance some tenons so that there is a higher chance that the buccal mucous membrane you put on, you stitch onto the recti insertion sites, and also to the sclera. So the blood supply is mainly from the anterior ciliaries, but also from the vascularized cornea and any tenons that you've advanced. Obviously, the mucous membrane must not be too thick or too thin, and also must not be too taut or too loose. Too taut, then the vessels can't go in. Too loose, and then you have a potential space underneath which can accumulate fluid or blood. So the clinical course after stage 1, if you're lucky, then you will see that the original epithelium will be lost, and then you have granulation tissue, and then you form new epithelium after about 3 weeks, and then it looks good, and you can prepare for stage 2 surgery after 2, 3, 4 months after stage 1, the stage 1 date. So come stage 2, your lamina has been resting in a submuscular pocket underneath the lower lid of the contralateral eye. And for 3 reasons, it needs to stay there to recover from the thermal trauma of the grinding and drilling. And also, in case there is infection, it would be best that the infection manifests itself in a vascular area rather than on your eye. And finally, it needs to acquire soft tissue, because it is the soft tissue which is invested into the bony part of the lamina, which is used for stitching onto the eye. So you have retrieved this, and you remove all the soft tissues from the dentine side, but from the bone side, you trim off excess and leave some for suturing. So on the eye itself, you reflect the buccal mucous membrane, and you expose the cornea, and you put a mark in the middle, and then you have then put in a flaring ring, which is used to support the eye, because once you open the eye and remove the iris and the lens and the vitreous, it can collapse. So whilst all that is being done, the flaring ring is supported through 2 longer sutures by an assistant, so that it doesn't collapse altogether. So your iris is removed by iridodialysis, and your lens is removed by cryo extraction. I experimented in the first few years of my 25 years as a K-Pro surgeon. I experimented with ECCE. My teacher was very annoyed with me, and he was right, because the glaucoma rate was higher. The de novo glaucoma rate was higher with ECCE. So then you remove quite a lot of vitreous, and then you put the tooth back on. There are pre-placed sutures there, and then you reinflate the eye with sterile air. You look in, and this is often the first time that you would see the optic disc and the macula. There is a vogue in looking in with an endoscope to see what the back of the eye looks like, even before offering OOKP surgery. Okay, so then you put back the mucous membrane and you make a hole for the optical cylinder to poke through, and you close it, and that's it. You know, the operation is finished. Now, sometimes there is not enough protrusion, and the mucous membrane can grow over the optical cylinder. Now, I've already said that the OOKP really owes the success to my teacher through incremental modifications over a period of 20+ years. And in the last 2 decades, the innovations have come from ourselves in Brighton and Dr. Ayer's team in Chennai at Sankara Nethralaya. Now, these are 3 key publications that you might look at. Okay, so there's the Rome-Vienna Protocol, when the then teaching group convened to agree on the exact technique. Seminars is a very, very detailed article on the technique. And then there's current opinion. The article is all the updates up to 5 years ago. So I've already talked about the cross-section anatomy. Oh, by the way, I don't know whether you can hear some music. This is from the stadium opposite the Mandarin Oriental. I think they're rehearsing for the National Day. I'm so sorry that they're so noisy. Now here you see a unique chamber eye, and here you can see the OOKP lamina. This is a PMMA optic. The only part of the OOKP that goes into the inside of the eye is the posterior part of the optic. The anterior part of the optic goes through the thickness of the OOKP lamina, the dentine, the alveolar ligament, and bone. Now the bone lives, and the alveolar ligament is also living. Dentine dies. The moment it's denervated, it dies. So it was dead for quite a long time now. And the buccal mucous membrane keeps the bone alive, and it shrink wraps the lamina as well. Now the optical cylinder is kept in place because it's a very, very tight fit, but also the intraocular pressure has a tendency to keep the cylinder pressed against the back of the lamina. So let's have a look at the anatomy of the OOKP. What makes it work so well? So you have the buccal mucous membrane graft. It is actually a very tough tissue, and it keratinizes when dry, and it forms a biological seal. The physical shrink wraps the tooth. And I've already said the vascular supply from the periphery of the mucous membrane graft goes to the center, and then supplies the bone. Now the lamina itself, the gradation from dead hard plastic to dead, highly mineralized dead dentine, to porous living bone, to the living buccal mucous membrane graft, this tricks the eye into accepting a bare optical cylinder. Now, if it were just the optical cylinder without this framing with a biological frame, then it would be encapsulated and extruded very, very quickly. So it is actually a con act to fool the eye into accepting it. Now, the fact that there is no iris means that there is no breakdown of blood aqueous barrier and reduced cystoid macular edema. There is still iris root, so it can bleed from there. And also, we don't know when pulling out the iris what damage has been done to the trabecular meshwork. And also, the iris root, presumably when you stitch on the OKP lamina and you compress the anterior chamber, it is conceivable that there is still some occlusion of the trabecular meshwork. Now, no lens, that means that there is no subsequent cataract removal. Can you imagine trying to access the cataract? You'll have to peel back the mucous membrane, and then you probably have to do the lens extraction endoscopically, or you remove the lamina and do it open sky. So therefore, I mean, the world is agreed that even if the lens is clear, you still remove it at the time of OKP surgery. Now, what about the purpose of removing the vitreous? Well, ideally, I think we're now agreed that ideally no vitreous. So maybe, you know, a primary endoscopic vitrectomy when you have a look at the posterior pole is a good move. If there is zero vitreous, then there is reduced risk of retinal detachment, reduced risk of cystoid macular edema, and reduced risk of blockage of the inside of any glaucoma drainage device. Well, so here are my own results in Brighton. This is graft survival with prophylactic exchange. Now, you might say that is cheating, but what it is, this is the same results on the same eye. So if I feel that the device, there's impending failure, then if there is yet another tooth, then I will prepare another lamina and exchange that after 2, 3, 4 months, and to extend the life of the OKP. So let's say you can consider that it is still the same wheel, but we have changed the tire, and so it keeps working. So you can see actually it is pretty good. The chance of retention of with prophylactic exchange, that over a long period of over 200 months, that's many, many years, that we have over 90% a chance of retention. And equally, if we just look at the allografts, then we have 60% chance of retaining 612 or better over some 200 months or above. Now, let's have a look at the complications. Luckily, with the OKP, when it comes to complications, it usually gives months of warning. So if you are seeing the patient every 3 months, then you have a very good chance of detecting that there might be something wrong. But that's not always the case. Sometimes you can have a surprise. So for example, nothing can detect a hairline crack, and a hairline crack only discovered at explantation could mean that you can still develop endophthalmitis. Now, just before flying out to Singapore, I had another surprise that an OKP patient had the eye bashed, and the optical cylinder became displaced backwards by a millimeter. So his sight changed, but also there's aqueous leak. But I couldn't get OT time to fix him before flying out to Singapore. And also because he has a tracheostomy, we needed to get a whole team ready for him. So his repair will now be Wednesday next week. So you do have to, if you want to run an OKP service, you need a comprehensive team to be ready to jump into action. And where in Brighton, we have had a comprehensive program and personnel to detect and manage to improve detection and management of all of these complications of laminar resorption, which I will go into. All sorts of oculoplastic complications. Well, they're not really sight-threatening, but they do need attention. Now, glaucoma is sight-threatening and needs attention, and nowadays it is a Bevel 252. And vitreoretinal help when it comes to should there be a rhegmatogenous detachment or vitreous hemorrhage or endophthalmitis, we do need their help. Right, so let's have a look then. Resorption of the OKP lamina. Well, there are warning signs like elongation of the visible part of the anterior optical cylinder, So that could be early. Tilting could be early, but when there is change of refraction, aqueous leak, or anything else, then is when it's unstable, that's too late. Okay, so every quarter when they come, I palpate the lamina for bulk and for its integrity. The mechanism of laminar resorption is not known. There might be a problem with the tooth to begin with, and there could be problem with thermal damage if it's not irrigated properly when you're preparing the lamina. There could be bacterial action, and of course, the primary disease may have affected the tooth. So your mucous membrane pemphigoid, a very major indication for OKP, it does affect your mouth as well. So imaging is very useful, mainly some form of CT scanning, and I'll go into that in a little detail. I've already told you that we can make a new lamina and then exchange after 2, 3, 4 months if there is time. Now, if it's very, very urgent and it's already leaking and cannot be repaired, then explantation would be necessary so as to preserve the visual potential, and you close the opening in the cornea with a small full thickness corneal graft, and then go back in the eye when you have another lamina or an alternative device. You can also rebuild the lamina in situ, and this is an invention of Dr. Geetha Iyer. So here you can see electron beam tomography. So AV technician, if you can help me play the left-hand video. So here you can see with 3D reconstruction, you can see the lamina. Now this is an intact one, and it's wonderful. Okay, so let's go back to the slides. Do I have to reshare?
Yes, please. You have to reshare on your end.
Oh, okay. Okay. I do beg your pardon. Okay, then, so apart from 3D reconstruction, you can also look at linear measurements, and you can look at volumetric reconstruction as well. There is software which is used originally for looking at lung tumors that we have adapted to look at volumetric, and that's objective, and you can get a number like so many cubic millimeters. Now, what possible solutions are there against laminar resorption? So we now agreed that we should aim for 3 millimeter or thicker as a lamina. However, if you make it too thick, then your optical cylinder will not protrude enough and you'll have mucous membrane overgrowth. Well, you can have longer optical cylinder as well, but the longer it is, the narrower the visual field. So it is a compromise. Adequate cooling. Now we've already talked about this. Imaging is important, but cannot detect hairline crack. Alendronic acid, I have shown that I haven't shown it to the statistical significance, but anybody who's showing signs of resorption, I will put them on alendronic acid, which is of course used for osteoporosis, to try and keep the bone as dense as possible for a longer period of time. So I've already gone through volumetric analysis. Let's have a look at the case of this middle-aged lady with Stevens-Johnson and had stage 2 OKP in 2004, and the mucous membrane did not behave. So she had lid cover of the OKP, and she's actually the only person who had lid cover, because all my other cases, we were able to use mucous membrane cover. So she had 6/5 vision. She still has that, thank goodness, but it is the only eye, and she didn't have any other tooth to go. So we have the issue, the challenge of diminishing dimensions of OKP lamina over the years, and it's putting the lamina at risk of extrusion and the eye at the risk of endophthalmitis and retinal detachment. So here you can see that there is a notch, various views, and we know that she is at risk. So here you see this technique developed by Dr. Geetha Iyer. So bone chips, this is the very first case I did. Now the chips are crushed even smaller. And here are bits of sponge soaked in bone morphogenetic protein. And you might think I'm cooking, but I was actually mixing the sponge with the bone fragments. And here you see I'm going through upper lid and then going in to right into the surface of the OKP lamina. So let's go forward a little bit to save time. Okay. In fact, I didn't do this quite right. I didn't remove enough tissue to expose the bone of the lamina, because that's what I should have done. And having done that, you close it and you then hope that the bone fragments would attach. So, okay, so let's go to the next slide. I'm sure I will be able to manage. Okay, so the first postoperative week, you see bits of bone there. And then later on, using a 3D reconstruction, you can see that these bone fragments. Now, in the longer term, for this particular intervention, it hasn't really worked. And that's because I was still learning. And she has since had a repeat procedure and the bone incorporated. But then through this intervention, the lid and the brow dropped, and I had to do a brow lift and brow fixation so that the OKP cylinder wasn't covered. So now let's have a look at this video. Now I'm showing a number of oculoplastic videos because I know that Blanche wanted to see this. So let's play this. Now you can see that this is after stage 1, and they are thin areas, and this area of thinning would not be capable of supporting the lamina. So I went beyond the area of thinning and then took off the epithelium. Now there is actually no need to remove all the tissue to show bare sclera or bare cornea. You just need to be sure that there is no epithelium. So fluorescein showed that there is no more epithelium. And so basically now it is a bipedicular pedicle. So I go as far up as possible, and I open it and undermine it. And now you can see sclera. So people ask, well, why don't you just put a new graft over the central area? Well, that won't work, because the reason why the first bit didn't work was because there was not enough blood supply. So you move an area which is still receiving a blood supply from either side, and then you check the area of the bare area. You just tie up the lid temporarily whilst you go and get more mucous membrane and get it into shape and into size and suture that. So this kind of surgery I have been doing myself, and so because it's in the periphery and then it vascularized, and mostly this will work, and you can see a conformer and ciprofloxacin or chloramphenicol ointment being put in. So that's that. And can you show the next video, please?
Sure.
So the next video is to show after stage 2, there is mucous membrane ulceration showing the exposing the bone. So you can see that firstly I used a burr to thin down the bone a little bit, and then this is done by an oculoplastic surgeon. So freeing up a pedicle, and then using an element to rarefy the buccal mucous membrane graft surrounding the area, and then advancing that and stitching on, and then also anchoring it so there is not too much tension. Then afterwards, you can either cut the connection or just leave it in place. So yeah, we don't need to watch the stitching. So let's stop the video, and then I will go back to my slides. Okay, so here we are, yet another video. So here we have an example of overgrowth. And so in Brighton, we've developed an algorithm. So firstly, if it's just minor, then you desiccate the ocular surface, and hopefully then it will just retract itself. Then secondly, you can just trim it. And thirdly, you can trim it like I have done, and then apply mitomycin C pledgets, just like when you do glaucoma surgery. And finally, if that doesn't work, you will have to peel back the buccal mucous membrane and then trim it submucosally, and also trim any excess soft tissue over the bony lamina to deal with the problem. Okay, so there will just be one slide on glaucoma, and there is pre-existing glaucoma, obviously, you know, with ocular surface disease and steroid use and many other things. There is already a high incidence of glaucoma of up to 50% before any keratoprosthesis surgery. But also there is a rate of de novo glaucoma ranging from 1/4 to 1/2. So the problem is when you have an OKP lamina, there's no exposure of cornea. You can only ask the patient to look down, and you feel the pressure through your fingertips where there is no bone, okay? So through the upper lid and avoiding the bone. It is also possible to use a cotton tip to indent the medial and lateral buccal mucous membrane graft where there is no bone. You can do that too. You can also look at the disc appearance and do OCT, do retinal nerve fiber analysis and electrodiagnostics. You can, what you would be using oral acetazolamide or oral beta blocker if the patient is allergic to sulfur. And you can also use sublingual timolol to lower the pressure. But topical anti-glaucoma drops will not work because there is no absorption through the thick mucous membrane. Well, we've tried all sorts of other surgical procedures, but they haven't really worked in the long term. So nowadays, I use a Bearvelt 250 and either put a supramid in or ligation and so that there's no hypotony in the first few weeks. So I think it would be beneficial to have a new tube design, possibly pre-placed, and possibly in conjunction with a primary endoscopic vitrectomy for OKP eyes. And also an intraocular IOP sensor and a one-way release of aqueous would be beneficial to keep the long-term health of OKP eyes, because glaucoma over the long term is a major thief of sight from OKP eyes. So I'd like you to please show the final video. So we'll just show one part of this. And this is a video of the first Bearvelt that I did. So the usual thing of testing patency and putting in the supramid. And you can see that I'm covering the anterior part of the optical cylinder with a little bit of tape, because I don't want the microscope to burn the macula. So having marked and having gone in, straight blunt scissors all the way in to open up a large area to take the Bearvelt tube. And as usual, I'm showing to you that you think it's a big enough opening and space, but it's not. So you do it a bit more until there is enough space. So you see, actually, I'm going through the needle. I had no space to exit through the opening. So I went through mucous membrane and then retracted through, and then with the tying, I went through the hole with the blunt end to reduce the risk. Okay, so we've fixed the plate, and then it's a matter of trimming. And you see, you know, that is far too long, and then the shorter the better. But on the other hand, because there is still a frill of vitreous, you don't really want the end at the tip of the tube to be still within vitreous. So that's why it would be good to be free from vitreous altogether. Okay, so and then you do a figure of 8 just to stabilize it, and then close. Now, closing of the buccal mucous membrane is with 6-toe vicryl, and it is important not to do through and through to 80% depth, because you don't want the suture track to go into that dead space, which is in communication with the inside of the eye. You don't want that to be a source of endophthalmitis. So you hide the supramid. You know, I try to dye it, but actually it doesn't work. You know, you lose the dye, and there's always a job trying to find the supramid. So there is actually a second procedure to get the supramid out. Okay, so in the interest of time, let's stop the video, and I will go back to the slides to try and close as soon as possible, so as not to overrun too much. So could you stop the video for me, please? Okay, so we've looked at the strengths of the OKP. Of course, there are weaknesses as well, like the complexity and the number of stages, the oral damage, the requirement of a suitable canine tooth, the cosmesis, the oral medications, the Diamox, acetazolamide, which is often lifelong, because even with a tube, it may not be giving sufficient pressure control. And then globe access for any vitreoretinal and glaucoma procedures is a hassle. You know, it takes a long time to get access to the sclera for your VR colleague. And it's not suitable for children in that the OKP lamina resorbs very quickly in patients under the age of 18 or 19. So I've told you a little bit about Boston K-Pro type 1. The type 2 is a completely different beast. And I would say, so this is the letter to the editor that you must read, because I found that there was a little bit of a misleading article on the capability of the Boston K-Pro type 2. The OKP is king in terms of anatomical retention and long-term retention of vision, and a number of complications for eyes which need an OKP. And even in Barcelona, where they have been doing tibial K-Pros for a long time, they're going back to the OKP. And Conrad Hiller's results also confirm the superiority of the OKP, and my results as well from Brighton. So where there is no tooth, what are you going to do? And no tooth also means no suitable tooth. I mean, there might be a canine there, but it might just not be usable if there is gum and bone recession. Now, the major point here is that alternatives do not last as long and do not proceed if the patient is not prepared for reduced longevity. So the kind of story I tell patients would be like, I asked them about whether they know the fable of the mermaid living in the sea and wanting to come up to land to meet Prince Charming, and she wants to lose her tail and have 2 legs. But the thing is that she would be able to come up, but she would only last a short time, and then she will die. So I tell this kind of parable, and they say, yes, I'm prepared for a more short-lived device because I really want to see again. I want to see my children or my grandchildren, even if it's for a few months or for a year or 2, I accept that, but I still want to see for that brief period. Okay, then go ahead, otherwise don't. So here we have an algorithm which is published. Essentially, if there is a suitable canine, then then you can use that, obviously. But if it's a borderline tooth, you take it out to determine its suitability. If it's suitable, then you go ahead. If it's not suitable, then you wake the patient up and then plan for the future. And then these are the alternatives, really. The Boston type 2, only if there's sufficient lid cover. And then the Pintucci, you need to check device availability because it's not very available now. The tibial K-Pro, you need good density of tibial bone, and there's no way of easily checking bone density because the usual things that people check for osteoporosis, it doesn't predict tibial K-Pro, tibial bone density. Now, there are the modified Boston type 2, for example, the LVP. Again, you can check for availability. Allograft OKP doesn't nearly work as well. And then there is also the Lux K-Pro, which was an experimental device of which I was part of the one of the investigators. It is actually getting pretty good results, but it's not available at the moment because we want to wait a few years to see how it does in the longer term before making modifications and then doing the next round of trial. Of course, you can try and use a synthetic OKP lamina, and here are some prototypes of using titanium and titanium oxide. I think in the interest of time, I will not show you the Lux K-Pro video. So future developments, I think thin intralamellar device utilizing titanium or similar, which avoids the requirement of donor carrier, will replace the Boston K-Pro type 1. So there are many Ukrainian and Russian devices which have not really had a proper look at yet. The synthetic OKP will, I think, have a future. I think the Boston type 2 K-Pro will morph into an epiconial device and the buccal mucus membrane cover. And the Boston K-Pro type 2 really needs renaming because it's a different beast altogether compared with the K-Pro type 1, and there's no point confusing users and the non-aficionados. And I think full endoscopic vitrectomy at the time of evaluation, an intraocular IOP sensor and automatic valve release of aqueous will be the future. So I think that is it. I haven't overrun too badly. I'm happy to receive referrals. I'm happy to teach. And I have taught in Japan, Singapore, India, Malaysia, Jordan, Egypt, Iran, Australia, and so on. But of course, there are requirements, there are team requirements. And it is important for the team and especially for the K-Pro surgeon to be adequately dedicated and devoting to their professional life to the science and art. That is all. Thank you very much. And here my email address is if you want to contact me.
Thank you, Professor Liu. Excellent talk. The floor is now open for the questions. If anybody want to ask any questions. I think I'll start first. I mean, there are a few questions already. So one question from Shamin Chai. Do you prophylactically place glaucoma tubes in all of your OKP patients given the fact that there is a high incidence of glaucoma?
Okay, so that's a very good question. If it were like magic, then it would be wonderful. But the problem is, if you put in an implant first, and okay, you don't connect it yet, but then you have to coil the tube, part of the implant underneath, and then retrieve it later for implantation. So I think as a concept, I think it's a very, very good idea. And this is what we would be striving for with a new design, specially designed for the OKP. And you know, like when you take a shower, sometimes your shower tube would be plastic. Other times there's a metal surrounding around it. So I think then ideally the tube would be partly metal to protect its rigidity. The other thing is the tube also can be without a tube, but rather it has a perpendicular tube which is solid and it punctures directly into the unichamberi. So many things. I see there's a question from Prof. Graham Holder. It says in the preoperative assessment procedures, there was discussion of patients who did not require electrophysiology. When I was at Morpheus, I saw a number of your patients. Which are the ones that do need electrophysiology? Okay, right. So the patients with very brisk projection, accurate projection of light, they do not need electrophysiology. But those who don't, and I'm worried about visual potential, then they used to go to Prof. Holder for electrophysiology, and also some patients whom I think actually really have no hope, but I can't convince them. So I send them to Graham to show that there's like an extinguished flash ERG and hardly any VEP, and then, you know, that's kind of like hard evidence. But even then, some patients would still demand surgery. So have I ever yielded? Only on one occasion, because she told me, if you don't do it, I'm going to get somebody else to do it. So I said, okay, I'll do it. And of course, post-op, it was just perception of light. And I think there are some Q&As as well. Prof. Ray, do you want to moderate that, please?
Yes, so there's another question from Dr. Sani Shen. What is the average size of the buccal mucosa you use in the OKP?
Okay. So I ask for from my oral surgeon. Sometimes I'd take it myself, and I would avoid the parotid duct opening. So I want 3 centimeters diameter. That's what I want. Sometimes I don't get that, 2.8 centimeter would be acceptable. Then what happens then afterwards, I would trim the excess fat. And then after trimming, then I feel it. It feels about like chicken skin, uncooked chicken skin. That's about the right thickness. And then I stretch it, and then I cut it to size, and then it would be roughly the same size. I never cut it too small because I don't want it too tight. I cut it either just the right size, hopefully, but if it proves to be too big, then I have to trim it in situ whilst I'm stitching it. So that's the rough size.
I think that answers Shani's question. There's another question from Weebun. Apart from your OKP surgeons, what would be the training like for the dental surgeons?
Okay, so I think it is important to have a team, and there should be, for each team, for each role, there should be a named person. So usually it would not be a dental surgeon, it would be an oral maxillofacial surgeon, because most dental surgeons would not be so bold to cut bone like that. The training will take some time, and I would advise choosing somebody who is very obsessive, because the majority of oral surgeons, because they are used to working on a much bigger area, they will not pay attention to point, whatever millimeter or micron kind of precision, which is actually necessary. And there's so many things like trying to keep the periosteum and making sure the hole is drilled perpendicularly, and taking it in very, very small stages so that the optical cylinder would fit very, very snugly, because even if it's slightly loose, you're compromising the patient, because there are so many steps of surgery, and each step can compromise the next step. Every step needs to be perfect. And because the case number is low, therefore the training period is long. Of course, I mean, if the trainer is not available in the long term, then you start and you make mistakes, and you consult your trainer or trainers remotely. But there will be casualties. The longer the training, the fewer casualties.
Excellent. I think one more question here. One question is that what is your retention rate of OKP in your practice?
Okay, so I have shown in that Kaplan-Meier curve that the retention is around 90% in 220 months. This is with a prophylactic exchange of lamina, because when I feel that one is getting too small or imperfect and the eye is at risk, then I will do a prophylactic exchange. So it's not bad, I'd say.
Thank you, Professor Liu. Is there any more questions from the audience? I think a few more questions coming. Okay, so here is a question from Dr. Ganga. Who is or have been the oculoplastic surgeons you have worked with over the years?
Do you mean, sorry, which, let me see, just check again.
Yeah, so are you
oculoplastic surgeon?
Yeah.
Oculoplastic surgeon. Okay, so I've had in Brighton, I've had Paul Britton. I've had, now we have 3 oculoplastic surgeons. They haven't helped me very much. I've had David Verity. I've had Raman Malhotra. So those are the people I've worked with. But a lot of what I showed you, I did myself, because before choosing to become a corneal surgeon, I was also considering oculoplastic surgery.
Yeah, I did. We all saw that as well. There is another question from Dr. Shamira from SNC. Any success with the methacrylamide for IOP lowering?
Oh, hello, Shamira, and congratulations on your prize. I saw it in all the lifts at SNEC. Now, you must tell me what methacrylamide is, and we can do that offline, okay?
Okay. One question from Dr. Doric. If removing the vitreous is important, might be beneficial at stage 2 to put on a temporary K-Pro, or do the lensectomy or vitrectomy is better?
Let me see. Doric says, might it be beneficial at stage 2? No, Doric, my idea is to do a primary endoscopic vitrectomy before stage 1. So that makes another stage yet, but never mind.
Okay, so I think we have one more questions here. Is it a common practice to use betadine solution to irrigate the eye before inserting the bandage contact lens in case you are using the type 1 Boston K-Pro?
Well, I haven't seen it done, but I hear that is a pretty common practice. Yes.
Okay, I think one more question from Chris Lim. Let me see.
Okay, so the cleaning, to begin with, after surgery, there is ointment 4 times a day whilst the wound is still recovering. So there's no point cleaning because very quickly you're going to be smearing it all over again. But later on, the ointment is only at night time, and mostly patients don't blink, so they don't smear, or they learn not to blink. The cleaning is with lemon juice. So you cut a lemon and you dip a cotton bud into the fresh cut surface of the lemon, and you then get some juice, and then that cuts through the grime, and then you dry it with another cotton bud. It is important that patients don't scratch the optical cylinder because it's plastic, it can be scratched. And if it's scratched, then the visual quality is not as good. And some people are too vigorous with the cleaning. And then if they press too hard, they can loosen the optical cylinder as well.
Okay, I think, Chris, that answers your question. I think we're running a little bit late.
Yeah, yeah.
Can take the last question if anybody has. Okay, so if not, I would like to thank Professor Chris Liu again for the excellent talk, and thanks everybody for the joining for this CME this afternoon. Thank you very much. Thank you.
Thank you, Prof. Ray. Thank you, everybody.
Thank you.
Bye now, till next time.
Bye-bye.